Great. Good morning. Um, so as you see, we're going to talk about palliative care and heart failure. I have been seeing patients in the heart failure clinic for several years now, and it's been a roller coaster. So hopefully, I'll be able to share some of my experiences with you, and would love to hear any words of wisdom or experiences that you might be having in your organization. No disclosures. We're going to talk about the heart failure types and classifications, and some of the causes, and what the role of palliative care is in advanced heart failure patients, what those barriers are that we encounter, and even propose some solutions, and then discuss some special cases that are related to heart failure, like a removal of advanced therapies and some lifestyle medicine interventions. So just to start, we all know what heart failure is. It's a syndrome. It's not really, it's a cluster of signs and symptoms that's caused by abnormal cardiac function. And we typically will see the elevated BNP and evidence of both pulmonary and systemic congestion. There's, abnormal filling of the right or left ventricle and increased filling pressures, and it can also be caused by any structural or cardiac disorder that impedes the ability of the ventricles to fill or eject blood. So things like amyloidosis and those kinds of things that um, inhibit the cardiac muscle from doing that can also result in heart failure. So when we talk about advanced heart failure, and it's an advanced heart failure that we have evidence for the benefit of palliative care, we define that by, according to the European Cardiology Association, they define that as a chronic state of heart failure. New York Heart Association class 3 and 4. We're going to talk about the classifications in just a minute here, where we have reduced LVF of less than 30%, or even isolated right-sided right ventricular failure. Your left ventricle does not have to have a EF of less than 30% if you have isolated right-hearted failure, or any type of non-operable valvular abnormalities or congenital abnormalities with persistently high or increasing BNP, with evidence of pulmonary or systemic congestion that continues to require escalating or high doses of IV diuretics or combination of diuretics, where there are episodes of low output that require inotropes, like milrinone or dobutamine, or malignant arrhythmias, or that cause a one or more unplanned visit or hospitalization in the last 6 months, with severe impaired exercise capability. So, and all of these things need to be present for it to be classified as advanced heart failure. And I want you to sort of visualize what this patient looks like, because that's going to come handy further down in my presentation. So really, what we're looking at is we're looking at a patient who has signs of left ventricular or right ventricular heart failure. When you look at the labs, you're going to see that persistently or increasing BNP. Um, Treatment-wise, these patients become sort of diuretic resistant, and they are requiring IV diuretics or multiple diuretics to maintain the same diuresis. They might be already on inotropes, they might be on milrinone, or had one ED visit or hospitalization that was unexpected in the last year, and they have poor exercise capability. If any of you see heart failure patients, these are probably the majority of the patients I see. So that's the patient that we're going to be talking about. Heart failure is very common, and the prevalence is increasing in, gosh, 6 years now. By 2030, 1 in 33 of patients in the US will have heart failure. Currently, 6.2 million patients, if this is according to 2018 data, have heart failure. It was mentioned in 13.4% of death certificates, so a high cause of mortality. And it's very costly for the healthcare system. In 2018, the cost to the healthcare system was upwards of $30 billion, likely to double by 2030, again in just 6 years. It is the most common cause. 25% of readmissions within 30 days are caused by heart failure, and consumes 1 to 3% of total healthcare dollars. You can see how resource heavy heart failure is for our healthcare system and how costly it is. Just like in every other disease specific uh, treatment or cause that we talk about, the disparities in heart failures are just staggering. Anytime I present this slide, I sort of get kicked in the gut as if I'm reading it or learning it for the first time because it's just really uh, stunning in a very negative way. But racial and ethnic disparities in heart failure are well documented. We see it in the literature. And what they found is that um, the guideline directed pharmacological therapy and cardiac rehab are highly underutilized when it comes to looking at different racial and ethnic um, backgrounds for our patients. Um, IDCs and um, LVADs are also increasingly underutilized in racial and ethnic minorities. Um, and disparities in clinical trials are also evident. So even some of the evidence-based recommendations that are put forward have not been tested on women or uh, 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 our communities of color. And this is we're seeing this increasingly in heart failure. In order to address what is happening, and you all are a part of the uh, problem and the solution. So rest assured, yeah, we are a part of the problem, but we're also part of the solution. Addressing those disparities cannot be done only as an individual, but as individuals, we do have a responsibility to address those. Wherever you are in your career, whether you're a student or you're a fellow, whether you're a palliative care physician, hospice physician, the wonderful thing about the work that we do is we do have voices at the table. Many times, our healthcare organizations will solicit our advice as we help care for patients in a value-based way. And so you do have a voice to speak up. So looking at ways to further any new policies that might be in your healthcare system, to bring up ways to disseminate those policies in an equitable way, engaging your DEI committees if you have them, as you might be creating some of these policies. You might be available to help community-based interventions and risk factors and taking education to underserved or marginalized communities about the health risks, how to mitigate them. You may have an ability to be a part of making medication more accessible and affordable, and or you may be a part of a team that's been asked to be involved with the heart failure clinic, and so you may be able to remove some barriers about getting palliative care involved earlier on. So there's a lot of ways to be a part of the solution, um, and ultimately, really keeping in mind the way that systemic racism has been embedded in healthcare and many of our societal structures, and being mindful of that as we care for patients that come with disadvantages on multiple socioeconomic ways. So yeah, just knowing that these disparities exist sometimes helps us address them in even small ways, which is actually very impactful. So talking about the classification of heart failure for our patient population, we're looking at the class 3 and 4, where there is a limitation of physical activity. Many of them, if they're a class 3, they can be comfortable at rest, but small things like just going to the bathroom, getting ready for the day will result in fatigue or dyspnea. And the class 4 is when these symptoms are present at rest. So even just with a conversation or as patients are sitting there, they are feeling short of breath. They might be hypoxic. Even rest does not um, uh, resolve these issues, these symptoms. You all heard of the stages of heart failure, which is much more common in cardiology now. Again, for our purposes, we are going to be working with patients with the stage 3 and stage D. Stage 3 are patients with current symptoms or they've had symptoms of heart failure. So even if their symptoms resolve, they are still stage 3. And stage D is where patients have severe symptoms that interfere with life and they have recurrent hospitalizations, even though they have been optimized medically. If you remember the definition from advanced heart failure, this is the stage D. So remember that patient that we talked about. So that's the patient that um, uh, we're talking about in stage D. The trajectory of the heart failure when you're looking at those patients of class C, I'm sorry, that should say stage C, not class C, my apologies. The trajectory of the patients for stage C of heart failure. These are the patients again that have signs and symptoms of decompensated heart failure. And even if they've resolved, they still remain a stage C. Um, Oftentimes what happens is that they sometimes just present with that and that's when they get diagnosed. And with appropriate medical therapies, uh, their symptoms often resolve. They get diuresed, their blood pressure gets better controlled, their heart rate gets better controlled, and they no longer have the symptoms. But again, they still are stage 3. They then may have those exacerbations or those episodes more frequently, and sometimes they become just persistent. And then those continue to progress as their heart failure continues to um, worsen. Now, this is not a linear path, as you know. There's ups and downs, and they get better, and their symptoms feel better. So it's not quite the straight path like it is oftentimes in oncology. So this is the comparison of both the stages and the New York Heart Association functional class. So here, once you're a stage 3, you can actually even be a class 1. And this sometimes makes prognostication and eligibility criteria for hospice, which we're going to talk about, a little challenging because patients can go through class 1 through 4 even when they are in the stage C. And stage D tends to be a little bit clearer, and those patients typically are a class 4. So the classification by the left ventricular EF, again, I know you're all aware of this, so I'll just go through this quickly. When the EF is less than 40, we call it heart failure with a reduced EF. When it was 40, and with appropriate medications and maybe lifestyle interventions on a repeat echo, um, the EF has been back to its normal number of above 55. We don't say resolved EF. We call it heart failure with improved EF. So they remain in heart failure, kind of like in a stage C. Once they're in stage C, they will always be stage C. If the EF is if the EF is between 41 and 49, that we refer as mildly reduced EF. And if the EF is above 50, which is a normal EF, then that is heart failure with preserved EF. You're going to see this a lot more in the cardiology documentation. They've really moved away from using diastolic, systolic. I know in the hospice world we still use that language, but that's the classification that cardiologists use. Now, the clinical course of heart failure can be altered based on advanced therapies like LVADs or heart transplants or those kinds of things. But I want to talk just a little bit about just where palliative care might be um, helpful in this journey. You can look at just, first of all, the overall trajectory is kind of this up and down with these dips. And when heart failure becomes advanced and the patient's condition is progressed enough, it is appropriate to have some advanced therapies that might suit the patient's goals of care and their condition. Oftentimes, though, that doesn't really impact quality of life, as you can see on this graph on top. And at the time of initiating those advanced therapies, because sometimes the quality of life does not improve, even though maybe their life expectancy does, involvement of palliative care becomes really, really important. And here on the bottom slide, this kind of shows you the intensity of care. So even though some of these advanced therapies, again, may prolong life, it doesn't always impact quality of life and in a positive way. And it still requires an increase in intensity of care. So just to uh, keep that in mind where our palliative care services become even more important as patients receive these advanced therapies. So how do we predict the outcomes? It's it can be challenging. There are some objective prognostication tools that we can use. The Seattle Heart Failure Model, MAGIC, and Guided. I know that you're aware of this. See, when I use one, I typically use the Seattle Heart Failure Model. It's just what I've been using for a long time. It does have a lot more data to put in, so I do like to use that. But to be honest, I don't really use a model to predict the outcome. I tend to use it for more educational purposes with my patients. So if I have a patient where explaining the prognostication is a little challenging or where patients have a lot of questions, that's really when I tend to use the models. Personally, I don't use it to prognosticate our patients, but you should be aware of these models. And if you're not, play around with them just to get some awareness. I think I did my own for fun, and I'm not likely to die of heart disease, but you know, who knows? That was kind of fun to do. Anyway, the from a prognostication, once a patient is in stage D, they have a median life expectancy of 6 to 12 months. So really, if you think about that, all patients with stage D might need to be considered for hospice. Inotropes do affect quality of life, but they do not reduce mortality. So even for stage D patients that may be on milrinone that are not that may be New York Heart Association class 1 subjectively would still have a life expectancy of 6 to 12 months. So recommendations for palliative care and supportive care and end of life. This has been challenging. Oncology has really kind of come a long way from their partnership with palliative care. And that a lot to do, and I apologize for being a little cynical, but that has a lot, and how oncology was getting reimbursed. I think about 3 years ago, and that really changed the way oncology has been involving palliative care. Heart failure is not quite there yet. The recommendations, however, from the American Heart Association and American Association of Cardiology are quite clear. For patients with heart failure, palliative care and supportive care do show to have a positive impact on patients' quality of life. And it is a level of recommendation is intermediate. There's not a lot of studies done, but um, it is recommended. And the problem with this is that we just don't have a lot of studies. It's not that we don't think that there is a positive impact of quality of life. Also true with patients with heart failure that are being considered for life-extending therapies, or anytime anything is going to be discontinued, an ICD or anything of that sort. Again, this is the level of recommendation, and you can see how this is very impactful. Um, We don't, again, the studies are somewhat limited, but when patients are in stage D and they're being evaluated for any advanced therapies, including um, inotrope, milrinone, or anything of that sort, uh, palliative care really does need to be involved. And as you can see from the level of recommendations, we just need to have more studies done. So, why should palliative care be involved with these patients, and what kinds of things can we do? How can we be helpful? Well, we all know the you know the high quality communication that is so beneficial for every patient with every disease process. But if you remember that graph where patients' quality of life kind of goes up and down, it's not a linear graph. In those situations which become uncertain and unpredictable, high quality communication um, for the patients and the caregivers is just so critical and so helpful. So again, that's kind of our strength. So that's very impactful, but then also helping patients understand the prognosis. Because of the up and down trajectory of heart failure, it can be challenging for patients to really understand where they are on their heart failure journey. And oftentimes, physicians overestimate prognosis as well. So, to help patients understand what their prognosis is, we can really be helpful with that. That combination of educating our patients and making sure that they really understand where they are, but supporting them and not taking away the hope. The hope for the best and plan for the worst kind of a situation. And then also helping them clarify what their goals are. You know, um, as each time those patients dip and they have an exacerbation, they don't quite come back to their original baseline. So clarifying those goals as their condition progresses is also obviously very important. So, in summary, we do the shared decision making. It's what we do. We do it all the time. We use the head, heart, hands model with the 3 questions, really focusing on the health literacy piece, helping patients understand what heart failure is, how there is no cure. Heart failure has actually poorer prognosis than some malignancies. It's a chronic disease, and helping patients understand that, helping patients then identify what's important to them as they go along this disease progression, and then together creating the next steps. And that may mean no ICD, or that may mean an LVAD, but whatever the case may be, really partnering with the patient so that um, they have loud voices in their care plan, and they are the drivers of that. We help with symptom management. A lot of the symptom management that is done in heart failure is non-pharmacological. We do use medications, but opioids are not used as much as they are used in oncology. So that symptom management using an interdisciplinary team, some non-pharmacological approaches, and we'll talk about those and even some other medications, non-opioid medications. And then extending that support to the caregivers. Oftentimes we will see patients in palliative care if they're referred to us appropriately for a long period of time with heart failure because the trajectory um, can be quite long. So the recommendations are to involve palliative care when a patient becomes a stage C or a class 3 to 4. So oftentimes this happens when patients are admitted. So some of the primary criteria that we are using at Corewell Health for inpatient referrals, there's not a lot of data around what the criteria should be. Again, more studies are needed for that. But some of the surprise question is actually a really great question. Asking the cardiology team, would you be surprised if this patient uh, died in the next 12 months or before adulthood? The answer to that is no. That's a great reason to get palliative care involved. If there's frequent admissions for the more than one admission for the same condition in the past 6 months, if these symptoms are prompted by symptoms that are hard to manage in the outpatient setting, or they've just become more severe in the 24 to 48 hours prior to coming in, if there's complex care requirements, if there's social determinants of health that are just challenging for the patient to follow the medical regimen, and they're struggling with a variety of things that palliative care can be helpful with, or any other type of things that they might be using before in the outpatient setting or in their homes, and just a general decline in function. If they're if they're just becoming more dependent for their ADLs, or losing weight, or not eating as much, that's a great reason to get palliative care involved. So these are some of the primary criteria, and you don't have to have more than one of them to trigger a consult for palliative care in the inpatient setting. Hmm, sorry. Okay. Some of the supporting criteria, the secondary criteria that may make you think, yeah, maybe I'm thinking about palliative care. So any patient that's coming from a long-term care facility, that that could be, just heighten your awareness of maybe palliative care involvement is needed. Older patients that are cognitively impaired, and even just older patients that I'm not a ageist, but it is very true that older patients just don't compensate well for heart failure. So even though that alone is that criteria, again, these are secondary criteria that may make you just want to pause and think maybe of palliative care. Any type of uh, a malignancy, and it doesn't even have to be metastatic. Heart failure does put a great burden on the heart, and if patients have any malignancy, particularly if they're going to be considering treatment, that makes sense. That's a lot of burden. There's chronic home oxygen use. If there has been a history of an out of hospital cardiac arrest, if they've been enrolled with a hospice program, even in the past, and obviously if they currently are. I mean, if there's just limited social support, if there's a history of um, patients suffering from mental illness or, again, other social determinants, they may be having housing insecurity or food insecurity, things of that nature. And if there's just not even an advanced directive in place. So these are secondary criteria. Honestly, I look at uh, I look at the secondary criteria, and I could probably take a few of them and put them into the primary criteria. And what that really means is that getting palliative care involved earlier than later in heart failure makes a lot of sense. So, looking at the comparison between palliative care and oncology, how different that is. Oncology tends to involve palliative care truly when the treatments are no longer working, and we don't expect patients to actually move up and down in terms of their disease trajectory. So patients might be in their last 6 months of life. So, getting palliative care and even hospice involved makes sense, and that line tends to be more clear. Whereas in heart failures, you saw patients for stage D, class 3, 4, but we know that they can kind of move up and down if they're diuresed well, and they might feel like they're a class 1 or 2, and that make it seem like they may not be appropriate for palliative care, but they still are. Disease trajectory for oncology patients tends to be more linear. Once they start declining, they tend to continue to decline at a pretty steady pace. Not true for heart failure. Heart failure does have that wise approach where they have dips and they come back up, but they don't come back, to this quite the same baseline, kind of like how dementia is. And many patients with stage D can live past a year. So um, when the prognosis is greater than 6 months, oncology patients are seen in the clinics, and they may have home palliative, um, and they might be seeing, palliative care while they're inpatient. And hospice really does get involved when we're seeing that decline, and that last 6 months is pretty clear. Whereas for heart failure patients, they might be involved in palliative care clinics for an extended period of time with home care involved, with home palliative care. Their functional decline may have gotten to a point where they can't even live at home, and they've been in a skilled facility for an extended period of time. And so that line between palliative care and hospice is not quite as clear in heart failure patients. And again, for oncology patients, for medications and therapies, most of the we tend to have a clearer idea of when therapies are curative, and so a lot of times when they're discontinued or when the goals of care shift towards palliation, it's a much clearer point. um, Heart failure, the discontinuation of therapies is kind of gradual, and there's not really a point where we see that. And because of the longer trajectory of the disease progression in heart failure, we do see a lot of caregiver burden for patients because it's been going on for months and sometimes even years. So a little bit different for oncology and heart failure. So, my recommendations for those of you who are looking to embed palliative care as a part of your heart failure service line, education and partnership is absolutely very important, but ease the referral process. Take away the friction that might occur for the cardiology service to get palliative care involved. We've done some pretty cool things. We round with our um, a cardiology team. That presence. We can help them out. We can take the referrals quicker that way. We are really hoping to have an opt out for palliative care. Those of you who attended this lecture last year heard me say that last year, and I'm not going to give up on that. Just making palliative care, kind of an automatic involvement with advanced failure in the ambulatory setting, but still working through that. But just making that referral process easier, taking away that friction. And I cannot emphasize collaborate, collaborate, collaborate. Our operations team has done a fantastic job at really working through some of the barriers that keep coming up. But that collaboration, if I were to even take away the other three and just leave collaborate, collaborate, collaborate on there, that would be probably sufficient. So really work with your cardiology team, understand what their pain points are, um, and take away the frictions that you can, and collaborate with them to create a seamless care model for the patients. We did find that developing criteria and automatic triggers for palliative care referral has been very helpful. There are no, universal ones, but some of the ones that I showed you with those primary, uh, triggers, those are the ones that we use, and that does make it helpful. We are looking to embed that in our EMR, and so kind of have that as an automatic process, but not quite there yet. And there is no need to change the name of palliative care or hospice. We continue to have conversations about changing it to supportive care or, other things. And I personally think that palliative care is a great word. I think that people should feel comforted by it. We are going to alleviate suffering, so that what could be more hopeful and comforting. But there's many who think that maybe changing the name would make it easier for our physicians, our healthcare teams, and patients to utilize palliative care. I don't necessarily think that that's the case, but anyway. So, some of the common symptoms and how to treat them in heart failure, um, dyspnea is very common. Makes sense. Patients get fluid overloaded. It's a cardiac disease, obviously. Um, the first line of treatment for patients with dyspnea is cardiac medications. Make sure that they are not hypervolemic, and if so, a diuresis would be the first thing to do. Opioids are second line, particularly if patients are not responding to diuresis. There is no evidence for the use of oxygen. Benzos are second line, but you can also use non-pharmacological things like, you know, um, fans and those sorts of things if they're helpful. Inotropes definitely improve the symptoms of the dyspnea. And so if a patient is a candidate for that, or if they are on inotropes, it might be worthwhile to collaborate with your heart failure partners and see, is it possible to do a dose adjustment? So really looking at dyspnea beyond the use of opioids. Depression is very, very common. I think it's common in patients with with all chronic diseases. But 20% of patients have major depressive disorder. A lot of that is just due to the loss of what they're able to do. SSRIs can be a great place to start, and they can be quite effective. Avoiding TCAs because of the prolonged QTC, which oftentimes patients with advanced heart failure uh, do have conduction abnormalities. So, and they're elderly, so TCAs are not a good medication because of their anticholinergic effects. But again, non-pharmacological interventions, very, very helpful. Um, if you combine that with medications, SSRIs, I've had really great success with that. But again, patients have to be open to that. So pain, however, is the most common symptom, even more common than dyspnea. And upwards of 80% of patients will have pain with advanced heart failure, and just heart failure in general. And some of these pains are just generalized. They might be more specific in lower back, but pain is very, very common. 90% when patients get to class 4. It is absolutely safe to use opioids, particularly if they're in class 4 and their goals are for comfort. Um, and I typically, just use that nice WHO ladder, avoiding the NSAIDs. I think Norco is a good place to start with your patients. And as they progress, like I said, you just march on up that WHO ladder and use your opioids, but very safe, and they can be very effective. Again, non-pharmacological interventions like cardiac rehab, depending upon where, their functional ability, um, and focusing on sleep, and even other non-pharmacological interventions can be just as helpful as opioids. So I tend to use them in parallel. Fatigue, look for secondary causes that can cause fatigue. Don't make the assumption that it's due to the advanced heart failure. So patients do have OSA, treating that. Again, cardiac rehab, exercise, really addressing the isolation piece. Patients may not be going out and doing the things that they've loved doing or socializing, so using your IDT. Some of the lifestyle interventions that I want to really talk about is, lifestyle medicine did originate from cardiovascular disease. And Dean Ornish really started this, oh gosh, now I don't remember how many years ago, but many years ago, about how effective lifestyle interventions are for preventing, managing, and even curing cardiovascular disease. So some of the things that we do have a good evidence on is, there's the 6 pillars of lifestyle medicine: nutrition, movement, um, sleep, stress management, avoiding toxins, and social connections. Looking at the nutrition, a whole food plant-based diet definitely shows to be a moderate benefit in patients with stage A in heart failure. Again, it's a little bit seems earlier on, but also potential benefits in stage B and D. If a patient is open to changing their diet and it doesn't cause them stress, I will always talk about a whole food plant-based diet. I had a patient who was having 2 hot dogs for breakfast and 2 for lunch and 2 for dinner. And obviously, I did not talk to him about a whole food plant-based diet, but I did talk to him about reducing the number of hot dogs. So maybe 1 for breakfast, 1 for lunch, and 1 for dinner, and maybe adding a fruit. But, again, but if patients are open, this is very beneficial. Um, even in our advanced heart failure patients, sodium restriction can be helpful because that can cause fluid overload and then therefore dyspnea. So, it's not that, well, now you don't have to worry about that, eat what you want. That is true, but just paying attention to that. The other piece, the mind body, yoga, those kinds of things, um, they the Tai Chi, it's shown to have moderate effect in stages B and D of heart failure. But the thing of it is, well, maybe not no, but there's a very low risk profile. If patients are open to using any of these mind body techniques, I will always talk about it with them because it does show to have moderate effect. And again, there are no side effects. Supplements, that there's the evidence on that is conflicting. Some of my patients swear by it. I don't know. The only supplement that I will say for them to use is vitamin D, because there are some studies around the benefit of that. So those are some of the lifestyle medicine. The thermal vasodilatation using an infrared sauna blanket, I find fascinating. I've been actually recommending this to my patients, and again, this does again increase the disparities because you have to have the economical resources to actually buy one. They're not cheap. But if I do have a patient that I think can do that and they're open, the infrared sauna, the thermal blanket, um, The saunas, they heat the air to warm your body. Well, this actually just warms the body. And what it shows is that it reduces inflammation and it causes vasodilatation, and it can decrease edema and also decrease the symptoms of heart failure, with no side effects. So I think that's pretty cool. And if my patients can and they show a little bit of an openness, I will absolutely recommend that. I want to talk about a few cases. I think we have good time and hoping um, to share these with you. Our first case, it was a 59-year-old with ischemic cardiomyopathy with a left ventricular EF of 12%. Um, he was hospitalized for cardiogenic shock, and milrinone was started, and he wanted a heart transplant. But because of socioeconomic issues, with lack of support, he was not deemed a candidate for a heart transplant. But they were able to see him for an LVAD, which he did get. Initially, he did quite well, but then suffered a CVA. And his goals of care prior to getting the LVAD was that if he became bedbound or was no longer be able to be independent, he did not want to continue with the LVAD. And so after the stroke, um, he was paraplegic, he was bedbound, was no longer able to get up and move around. So he was very uh, aware and had capacity and said, I would like to stop this LVAD. So LVAD deactivation is very similar to removing a ventilator. We don't do it as often as vent removals, and so sometimes it seems a little bit it seems more complicated, but really it's quite similar to that. And just a couple weeks ago, Gretchen and our interdisciplinary team had a fantastic lecture around removing a ventilator. So, pull that lecture back up as we go through this. I'm not going to go through all of that piece, but just remember that as we go through this. Coordinating with the LVAD RN, because sometimes there's different LVADs. They might have different alarms and that sort of thing. So we always the LVAD RN at the transplant LVAD clinic. We give them a call. We share with them what the patient is wanting. They will be able to help us for any things that we need to know, as that we typically do this in the home. Then that education piece, that health literacy piece, no surprises, outlining the process to as much detail as we can, highlighting the things that we don't know, making sure that the DNR DNI is confirmed, it's documented, completed, and talking about the survival after the LVAD deactivation. We talk about that. It tends to not be very long. It's a little bit different than than vent removals. The vent removals, you can have patients that linger for hours and maybe even sometimes a few days, but typically we do not see that after an LVAD deactivation. But we never say that with certainty. Again, you just don't know. Our experience has been it's within minutes to hours of shutting the LVAD off. We should make sure that the other life-sustaining treatments, if there are any, should be discontinued. So if there's an IC, anything else, if there's tube feeds, anything like that, making sure those are all discontinued. You can have both oral and sub-Q available. We tend to do this with sub-Q medications if we can, but it's not always the case. Sometimes patients don't want it. They just don't want to have sub-Q line. So we do it with oral. So that's absolutely possible to do. Looking at what patients have used, depending upon that, deciding what doses to use and bolusing prior to the deactivation. We have an interdisciplinary team present there, monitor symptoms closely, and we treat them just like decompensated heart failure. And then again, providing the support to the family after the patient has passed away. Another case I want to share with you. This case is from a couple years ago. It's been a bit, but I probably will always share this case um, because this really highlights what it means to care for a patient with heart failure. And this was a 69-year-old female, a Black woman who had been hospitalized multiple times. I had missed clinic appointments and I just would was never I think she missed like six or seven, but had never seen me in clinic and had multiple ED visits and hospitalizations. I believe it was in the 50s. And this was she was seen in September. So for that year it was in the 50s or 60s. So many. And she had combined CHF with an LVF of 10%, history of diabetes. She had housing insecurity. She lived actually in the tents by downtown market. And then um, when those tents got cleared out, she just had no place to go and sometimes lived with friends or family members. But a lot of social determinants of health, many psychosocial factors, and had a lot of symptoms with chest pain and fatigue and dyspnea. When she was hospitalized, they reached out to us and said, "Hey, the patient that that's been on your schedule that you've never been able to see is in the hospital." So I went there at the time with our fellow, and we did our typical three-question approach, and she was very knowledgeable. She knew what heart failure was. She knew what it needed. She wasn't able to really follow the recommendations because she had no consistent place to live. And so when we were trying to identify her goals, she wanted stable housing, where she could weigh herself and have a pill box. And, we sort of was dumbfounded, like, oh gosh, that's not really what I know how to do. I'm not really sure how to help this patient. But the fellow and I, and it was Dr. Drummond, um, mostly Dr. Drummond did this, really reached out to our leaders at Corewell Health, and we were able to get her housing. She did accept hospice care and passed away with secure housing in 3.5 months. Um, Dylan did a great poster on that. If anybody wants to see that, the title of the poster was "Is Housing Healthcare?" And the answer to that, it is. So really recognizing the importance of all of those social determinants of health, housing being a really prominent one, and helping our patients, uh, through that. Because once she did have that, she was able to follow the recommendations. And so that was that was uh that was really an important one. Um, this this is a 90-year-old woman who has a history of diet controlled diabetes. She's got a preserved EF, heart failure with a preserved EF, hypertension. New York Heart Association varies between a 1 and a 2. She's got chronic kidney disease, stage 3. She had an unplanned hospitalization for dyspnea. She was hospitalized for 3 days, was diuresed and medications adjustment, was discharged to home because she refused to go to rehab. And she lived independently in her home, and did not want to go back to the hospital. She was very irritated the whole time she was hospitalized. And we got a hospice referral um, from her primary care doctor. Um, Now, if you look at this patient, she's 98. She did have one unplanned hospitalization in the last year. Um, she lives at home independently. She's got a New York Heart Association of class 2, sometimes goes to a 1. You know, is she appropriate for hospice care? Um, if we had time, or maybe we were in the same room, I would open that up for discussion. And maybe you can still share with me what your hospice would have done. Oops, go back. We actually did not admit her to hospice because we have a great home palliative program that is very easy to get involved. That's not the only reason. She really did not meet the criteria for hospice care. She's a class 1 to 2. She did have one unplanned hospitalization, but was not losing weight. She was still living independently. Now, being 98, could, if you think of the surprise question, would she pass away in the next year? Yeah, so definitely appropriate for palliative care. We got our home palliative care team involved, and she was very insistent that they not come often. It was just a very independent woman. Stayed in her home, lived independently. And then as she declined, and it wasn't that long that she did, we were able to transition her to hospice quite seamlessly. So it worked out quite well. I'm going to skip this case. We are coming to time. I do want to talk about the guidelines for hospice eligibility. The NIPCO guidelines talk about hospice eligibility at the time of initial certification or recertification. The patient should be a class 4 and be optimally treated, or so they have to be a class 4 and be optimally treated, or have symptoms at rest, like chest pain, or they can't, tolerate nitrate therapy, and they're declining or not a candidate for procedure. So class 4. And some of the documentation that is supportive to that is, any type of supraventricular or ventricular arrhythmias that are treatment resistant, having a history of cardiac arrest, any unexplained syncope, any type of embolized stroke, that sort of thing, commitment HIV, or an LVF of 20 or less. Now, if you look at that patient that we just talked about, the 98-year-old, I mean, she really did not have these symptoms. She was not appropriate for hospice care. I'm going to share with you what our hospice does. We don't only admit patients to hospice with the New York Heart Association Class 4. It is not as cut and dry. We typically will look at patients. If it's a class 4, that criteria, then obviously yes. But if we have a patient who has a class 3 and has some of these following ones. So for example, if they have class 3 symptoms, and they are just really fatigued, and their edema is just getting worse, and their symptoms, their other signs and symptoms are worsening despite medical treatment, and they're not quite class 4, we will take those patients. If they've had multiple hospitalizations or ED visits, or if they really just do not want to go back to the hospital, they are a DNR, they do not want any further treatments done, and they have other comorbidities, other significant comorbidities, we will admit patients with a class 3 to hospice with that. Again, telling that story of why this patient is appropriate, why we think that their life expectancy is 6 months or less, with a class 3. So that's what we do. And just take away, then open it up for comments, questions. It's a syndrome. It's unpredictable. It's progressive. Many symptoms. Non-pharmacological and lifestyle interventions are very effective, even when patients are in advanced heart failure. We got to address those goals of care to address the pain, even hospice eligibility. And interdisciplinary team approach is absolutely critical. So I'm going to stop sharing my screen and open it up for questions, comments, concerns, anything.
Well, thanks, Simin. This is wonderful as always. I had just a couple quick comments because I think you touched on a couple of things that I think are so important, I think, for the fellows and even everyone on because we've got a lot of folks that are kind of early in their palliative careers, beyond fellowship, and nurse practitioners and other clinicians on here. Two things. We have been working on the concept of triggers for, a couple of decades. Don't give up that that fight. As Simi said, it's so important that this become naturalized and an expected part of the process for many, many disease states. So just, for those of you that are involved in that, keep the pressure up because it's working. We're seeing that integration at many different levels. And the other thing that I agree, and I know that there's some controversy in this, but I don't think there should be, and that is our name, hospice and palliative medicine. The reason that people have objected to the words is because of the negative connotation that they have had socially, and certainly within the medical field. That in my opinion, is an issue of communication. We communicate what we do what we do, and people will learn, oh, I get it. And you can see those walls crumbling. So again, keep up the fight because I think it's good. Just one quick other question. Actually, it's more of a comment and a question, because you had commented, and I think this is worth emphasizing as well, that the science really demonstrates that inotropes will help to improve quality of life, but they don't extend life. I can't tell you how often I have a hard time convincing patients, families, and other physicians of that. They don't want to stop the milrinone because someone's going to die sooner. There's zero evidence of that, but that just seems to be the intuitive mindset that they have. Have you been successful in your realm of overcoming that? Because people say, well, can they go home on the milrinone? And I said, well, sure, but it looks to me like that they'll, they haven't been out of bed with or without the milrinone. It really hasn't had an impact on their quality of life, so I don't see the purpose in it. So I'm just kind of curious. I'll leave it at that.
We have had a great win on that. We have gotten our heart failure clinic to make palliative care an automatic referral for patients on milrinone. This is literally within the last month. And
excellent.
It's nice to hear you say you've been trying to do this for 2 decades, because I think it's been a long process. But now with the patient that's on milrinone, it is an automatic palliative care referral, and that's been great. So we have seen evidence of that, and it's hard, right? Patients, they feel better, so they think, oh my gosh, now I'm cured, or So yes, we've had some success. So we'll see. That's been great.
Okay.